Thank you, Eric. It's a privilege to be here and to discuss these new innovations in GERD therapy. I want to emphasize before I get started that I am not talking about the replacement of a nissen. And I'm not trying to implicate that, and I think most of the other speakers are much the same way. We're not really trying to do that, but we are trying to say that if we're going to make an impact in this disease of GERD as surgeons, we need to do some different things. And that's what you're seeing coming out. And I will kind of focus on that. So what I'd like to talk to you about is why we need procedures of a little less morbidity, and then introduce a few of them that haven't been talked about. All right, I do have some disclosures here, and that is I have been working with the Thorax Medical Corporation as a consultant, and I do receive a consultant's fee. This is largely work that dovetails very well with, has come out of our laboratory years ago. Now, it goes without saying that in the 1950s into the early, say, 60s was the golden era of anti-reflux surgery, mainly done open with these distinguished gentlemen, as you all know. It was at this time that the only alternative therapy that there was really antacids. And without question, surgery clearly showed a superiority in the treatment of reflux at that time. But I think now it's fair to look back at surgical therapy from 2013, where it is now, look back over that 40 years, and what can we say about those procedures? We did have a conversion to the open, to the laparoscopic in the process, particularly with a nissen. And what can we say now when we look back at that? Well, the first thing is that most of the procedures now, anti-reflux procedures, are performed by minimally invasive techniques. That certainly has happened over those years. That it does provide, these procedures very much do provide a very effective symptomatic control of heartburn and regurgitation. There's no doubt about that, and that's been well demonstrated and accepted. About 80% of the patients will normalize, maybe a little higher in different procedures. Long-term normalization, looking at it 5 years or so, about 80% will normalize their esophageal acid exposure. So it's a robust technology to stop reflux. The outcome and durability and the need for revision is definitely based on the surgeon's ability and experience. That we have also seen happen. It's not something that can be placed across surgeons universally. It definitely, its outcomes and so are related to their surgeon's ability. And that's not uncommon in other fields of surgery as well. If we think of the Carpentier ring for mitral valve regurgitation, it too, its outcomes too is very much based on a surgeon's ability and experience. We have now had to face straight on the fact that the procedure does have some significant side effects, mainly the inability to belch or vomit, gas bloat syndrome, flagellants, diarrhea, and temporary dysphagia, sometimes persistent dysphagia. In the past, when the nissens and the open procedures and the laparoscopic procedures were the only thing we had, and there wasn't a lot of competitive medical therapy that was good, we kind of didn't look at those too much. But they're there. And they're present and they're an issue. It's surprising that of all the people with proven reflux disease, some 20 million of them at least in the United States, and that's a low estimate, less than 1% gets surgical therapy. Less than 1%. Now that means that we are basically janitors. We're cleaning up a few of the problems. We are not really impacting this disease. If we really want to impact this disease, we've got to move up where disease is really bad over here. We need to move up higher when disease is less bad and apply surgical therapy. And the last point I want to make, I think we can say as we look back over here, it's not endorsed by the patient. Patients do not think when they got reflux disease, they want a Nissen. It's not endorsed by them or the GI community. That's where it is. Now, just to emphasize that, I just pulled three studies here, or three slides. This is a slide that was in the American Journal of Medicine, 2003. It was the #1 paper, first paper in the issue, showing the effectiveness of laparoscopic fundoplication in the community. Many of you have seen this article, showing that only 61% of the people who had it in Milwaukee were completely satisfied. And you can see it go on down from there. And new symptoms were common in 67%, consisting of gas symptoms, bloating, dysphagia, and 32% restarted their acid suppression therapy. Now that's not a great success record. And it's it's one of the studies that I think emphasize the things I said. Here's a compilation of side effects, and this is an open procedure. This is our 100 open procedures back in 1986. This is our first 100 lap procedures in 1989. This is this is by Bernard Delamage in 2006 with his laparoscopic Nissen fundoplications, and this is the most recent Lotus trial by Lindell regarding the laparoscopic Nissen. And you can see that the inability to belch is reported here, and here there wasn't even reported. The inability to vomit, you see this is about 63 to 25%, it wasn't reported here. But increased flatus throughout the years has been somewhere between 40 and 57%. And gas bloat syndrome, 15 to 40%. And persistent dysphagia, 3 to 11%. So there are side effects to this therapy. And this is a paper that will soon be out. I think you can get it electronically, written by our friendly gastroenterologist, Joe Richter. And you see complications of anti-reflux surgery in this very broad paper. And you see that the mortality rate, I think that's a little high, but that's what their study showed. The perioperative and immediate post-operative mortality, morbidity, the open conversion rate, early post-operative complications, late post-operative complication. Here's gas bloat syndrome, varied from his meta-analysis from 1 to 85%. Temporary and persistent dysphagia, recurrent heartburn, and the need for revisional surgery. You see 0 to 15, 4 to 10%. This is not a real formula for success. There's no doubt about it. You've got severe reflux disease and you've got horrid symptoms. A Nissen will give you a great bit of help, but not for earlier disease. And so if we're going to have an impact on this, we need to change. So I do believe it's time for a new surgical approach. A new surgical approach is needed, not a replacement of the Nissen, but we need something. If we're going to impact on this disease, we need something that is less morbid. And I think there's two reasons why we need this as surgeons. There's two reasons why we need to get together and make this happen. Number one is what we know about medical therapy now that the PPIs have been out for almost the same amount of period of time, what we can say about those. And the first thing we can say is that clearly there's evidence that the dose of PPIs is increasing. That is, over 50% of the people have gone to double doses over the last 70 years. The double dose has increased by 50% in the past 7 years. So they're giving more of the PPIs in an attempt to bring it under the symptoms under control. 85% of the patients on PPIs still experience symptoms of reflux. Now, this is all their own literature. This is where this is coming from. Doesn't mean that the people aren't improved, but they're still having symptoms of reflux while on PPIs. And it's just a matter of how much they're having that. But 85% of patients can be recorded. And the reason is that PPIs don't attack the cause of the disease, as we know. 80% of the patients will have, on PPIs will have nocturnal symptoms. So that clearly it's not a panacea as it's made out to be. 42% of the patients on PPIs supplement their prescription with other therapies, such as H2 blockers at night or Gaviscon or things of that nature. 40% on PPIs are dissatisfied. When you actually talk to them, they'll actually confess that they're very dissatisfied with their medication. Every morning they take that pill, they know they got a chronic illness, and they're still not getting the kind of therapy that they're satisfied with. And these are the people we need to be targeting from a surgical perspective. PPIs do not provide long-term cure of GERD. That is known. You're going to be on these medications throughout your life if you got severe GERD. And PPIs do not prevent the metaplastic and dysplastic complications of the disease. And PPIs have significant side effects. So there's a real big reason. This is one reason why we as surgeons need to look at these procedures with less morbidity. And this is well substantiated even years ago. This is an interesting slide out of the medical literature showing that recurrences with PPI therapy is related to the status of the LES and body function of the esophagus. If you have normal LES and normal body function, the recurrence of PPIs is very low. Symptoms with PPIs is very low. However, you have a defective sphincter, it's about 40%, close to that number that aren't satisfied. And if you have both body and defective LES, it can be as high as 80%. So you see, PPIs don't get at the problem. And this has been further substantiated recently with the use of impedance, pH. Here you see patients off PPIs. This is the number of reflux episodes they have. When they go on PPIs, they have the same number of reflux episodes. The only difference, of course, is the pH of the reflux episodes change. But basically, PPIs do not reduce reflux. Now the second question why we need to do something about this. One is that the PPIs aren't working as good. And two is the cancer problem. And I just want to emphasize here, the baseline cancer risk of the general population for esophageal adenocarcinoma is about 0.03 per thousand. Once you get Barrett's, non-dysplastic Barrett's, your risk of cancer goes up 200-fold. If you get low grade, it goes up 560-fold. And of course, if you get high grade, it goes up 2,000-fold. There is definitely a very strong cancer risk. It's equal to carcinoma of the colon in that sense. So this is a problem that needs, and PPIs are not affecting that. And I think it's a rather simple, logical conclusion to this. Reflux causes Barrett's. There's no doubt about that. Barrett's causes cancer. No doubt about that. Therefore, reflux causes cancer. No reflux, no cancer. We have an opportunity to, if we get early in this disease, to shut down that problem. I really believe it. So we've got good reasons to go ahead. So what is needed? This is what's needed. We need a safe, effective, affordable, patients like it, anti-reflux procedure that can augment the failing lower esophageal sphincter with minimal morbidity and insignificant side effects. It should be simple to perform with minimal dissection. It can be standardized, and it's reversible. We can get all of that. And what we've been seeing today is efforts in those directions, such as Stretta, TIFs, and a couple of other I'm going to show you. So one of the solutions to this problem is the thorax solution, which is a magnetic ring of little beads, magnetic beads, that can expand to close to about a 60 French. It's very small. It's about as big as your ring finger, the ring on your finger. Now, how does that work? And this is very important to get across because we as surgeons need to understand the mechanism of function in these various new procedures. Now, this is the function of the lower esophageal sphincter. It has a given length and it has a given pressure. And length and pressure are related to competency. As you shorten the length of the sphincter through gastric distension or other, fill your stomach up, it's going to be more and more pressure is going to be needed to maintain its competency. Now, there is a pressure less than 6 where no matter how long a sphincter you've got, it's not going to work. And most sphincters are about 3 to 4 centimeters long. So already you've got a sphincter that can't work if it doesn't have good pressure. Similarly, there is a length which any pressure you apply is going to have a difficult time to improve that sphincter. So right here in a corner, when you measure things in that area, this is a structurally defective sphincter when it's measured at rest. This patient needs a Nissen, not what I'm talking about. This is far gone reflux disease. But up here, in here where people can cross back and forth, we can augment that sphincter because it still can be worked with. And that's what these procedures do. Now, the process of a sphincter that isn't destroyed and why it opens is due to effacement, shortening, and then opening. And when it opens, you lose the LES pressure. So what happens as you distend your stomach with air or food, you apply pressure which reduces the length of the sphincter and effaces it into the stomach, much like a balloon increasing and the neck of the balloon getting shorter. And that goes until the length of the sphincter gets to a point that the pressure will no longer hold, and the sphincter gives away and reflux occurs. This is called a transient sphincter relaxation. in the medical world, but really it is a transient sphincter shortening that leads to relaxation. So if you stop the shortening, you can stop the process. I think what Stretta does is it makes the compliance of this stronger so that it's less likely to shorten with distension. And similarly, placing this little bead bracelet around the lower esophageal sphincter stops the shortening and stops the opening. It isn't the magnet squeezing the sphincter together. It just stops the shortening and stops the opening. So when it's together, it just stops shortening from gastric distension. There's no pressure on the sphincter itself. And when a bolus comes, the magnetic aspect of the device allows that bolus to pass because it can open up to let the bolus pass. That's how these things work. Now I want to show you the results of this device, this LYNX device. This is a recent publication of 100 patients with a 3-year follow-up, which was recently in the New England Journal. Here you see the patient's quality of life score off proton pump inhibitors, then on proton pump inhibitors, and notice the score improves but doesn't go completely away. And here it is 3 years after sphincter augmentation off proton pump inhibitors. This is what we can do. This is what surgeons can do with a variety of these techniques. And this is where we can impact this disease. This is median acid exposure, which drops from baseline here before, off PPIs, and at 1 year off PPIs after the application of sphincter augmentation. This is heartburn score with severe heartburn here and moderate here at 1, 2, and 3 years. This is regurgitation, which is basically a sphincter symptom. That's why PPIs have a big problem getting rid of regurgitation, because it's a sphincter system. When your sphincter goes, you get a lot of regurgitation. Here it is, the baseline, 1, 2, 3 years. Augmentation of the sphincter literally eliminates it. This is PPI use. As you see, drops down 1, 2, 3 years. This is gas bloat. You see there's more gas bloat pre-op than there is post-op, mainly because you swallow a lot of air to control your reflux. Afterwards, you don't need to do that. It does have dysphagia, because anytime you place anything around the esophagus, that will produce dysphagia. This gradually abates over 3 months, 6 months, and on down to where the patient is free of it. And when you look at their overall satisfaction score, this is on proton pump inhibitors. You see there's a number of people who are dissatisfied, but once they're off proton and have had sphincter augmentation, you can see the satisfaction rate is very high. I was going to finish, but my time's up. I just want to introduce a new one that's out there, just briefly. That is a new endostim solution, which is a pacemaker, which stimulates the lower esophageal sphincter, working from the other side. The LYNX works by, and the Stretta works by preventing the sphincter from shortening. This is working by increasing the pressure, by stimulating the lower esophageal sphincter. And you see that by stimulating the pressure, you hopefully avoid the transient sphincter relaxations. You can see the effect. Here's this pressure, the LES pressure. Pre-stimulation is down around, say, 7. Mid-stimulation is up here close to 15. And post-stimulation, it continues to persist for a while above 15. Here you see that it does not interfere with the lower esophageal residual pressure on swallowing, even though you stimulate it, pre-stimulation, 8, 15, 16, the residual pressure on swallowing remains in this pretty much the same area, 1.2 millimeters 2.5 millimeters of mercury. This nicely illustrates this device. Here you see lack of a sphincter completely. This is baseline. You turn the stimulator on. You see you reintroduce the presence of a sphincter, and it relaxes on swallowing. This shows a study of 24 patients, and this is what the normal value would be off PPIs of their GERD score, and when they're on PPIs, you see following stimulation, they drop the patients down out to 6 months, holding their improvement. So our hope for the future with all these new, what you're hearing about this morning, is that the LYNX or the Endostim or the Stretta could be an alternative solution to patients with gastroesophageal reflux disease who require chronic PPI therapy. Let's get rid of PPIs. Let's move them back to where they're on for about 2 months. And if a patient shows he needs chronic therapy, these alternate procedures, once we're convinced of their effectiveness, should be in our armamentarium. There's a lot of work out there to do. Thank you.
Thank you, Dr. DeMeester. Really compelling arguments. I guess we'll start with questions from the floor.
Sure, I'm Trip Buckley from the Scott and White Clinic. Quick question about all of these therapies, Dr. DeMeester.
Can you talk a little louder? I'm having a little...
Certainly, Trip Buckley from the Scott and White Clinic in Texas. All of these therapies, when you look at them as a whole, lots of people talk about patients going back on PPIs. So, you know, in the Stretta, LYNX, et cetera, there is a certain percentage who are going to go back on PPIs. What do you consider a success rate or a failure of some of these therapies in terms of, say, a 30-year-old patient comes in and we go ahead and we do one of these to get them off their PPI use, but if 30%, 60%, 20%, or 15% go back on PPIs, what do you consider any of these therapies to be a success long-term if the goal is to get them off PPI use?
Yeah, that's a good and fair question. I don't expect any therapy to be 100% at all. I think we're lucky if we hit that, but that's just out of sort of natural realm. I think we should be hitting therapy, though, that's around 90% with the use of there may be 10% of the patients who might need some additional medical therapy over against what the surgeon can do. I think we need to shift in also into a concept that we can work on this together. Perhaps a patient's not really satisfied with his PPIs, but if we can shift him down to where he now is very satisfied and most of them are off or some may be on, that's a success, as long as the procedure is a very minimal morbidity.
Next question.
Yeah, hi, Bill Chapman from Brody School of Medicine, East Carolina University.
Did you hear him?
Can you hear?
East Carolina University.
Yes.
Go ahead.
Yeah. All this morning we're hearing about some great options and gradations of reflux disease. Interestingly, only 1% of people are actually getting therapy. The vast majority of patients are being managed by primary care doctors and gastroenterologists. That is clear. There's hundreds of millions of dollars every year being put out by pharmaceutical companies to push PPIs down our patients' throats. How is it with 5 or 6 new technologies available that we are going to be able to fight that uphill battle to get patients to get appropriate management for their reflux?
Another very good and important question. First of all, there's a terrific push to sell these medications. I'm not against medications, but in the United States alone, it's an $11 billion industry. And anything that's producing $11 billion in revenue is going to be pushed very hard. It's called a medical industrial complex. And that's a problem. How are we as surgeons going to do that? Well, I think we need to think a little different. We are at the end of the chain, and we have not structured ourselves to impact the public directly. And I think Steve said this morning, or maybe it was Eric, that we need to market directly. We need to get patients exposed to our technology and what we can do for them directly. Now, maybe things will change with Obamacare as medical people and us are no longer reimbursed necessarily for procedures. We may find a shift in this, but I wouldn't wait for that. I do think we have to monitor, but all of us also have to do, I think what Eric said is we need to be global in our application. You know, to sit back and to think that, well, I'll get them when they send them to me is not the way to do this. You need to focus. You need to be able to do endoscopy. I think Brian brought that up this morning. You need to do your studies. You need to become immersed, I think, in a focused area like foregut. And then we can make a difference. And eventually, we will make a public difference when these people see what can be accomplished.
Kareem.
Yeah, Kareem Tratt from GW, Washington, D.C. Dr. DeMeester, we owe you lots of things, and among other things, the way you have laid out the therapy gap, you know, which is the philosophical argument behind which all these procedures are being developed. But I did have two questions regarding the LYNX. In terms of dysphagia, are you able to, because patients, when I sit with patients, and I do the TIF procedure, when I sit with them, I can safely tell them, you have a zero risk of dysphagia, and from day one. And that's really what sells the, you know, what will sway the patient towards that, the absolute absence of dysphagia. Are you able to tell this to patients? What's your experience with that component, which is the problematic component with the Nissen? That's my first question. The second one is regarding the reversibility. You did lay out the conditions for the ideal procedure and the reversibility. Can you tell us something about the failures of LYNX and having to explant, and how easy is that really to do?
Right.
Thank you.
Well, you know, anytime you do anything to the esophagus, you're going to have dysphagia, even sometimes when you just scope. Right, Brian? Sometimes. Not very often, but sometimes.
When he scopes.
But there's no question about it. So dysphagia is going to be part and parcel of our life. Now, eventually that leaves. And the patients are free of it, or they adjust to it. And when we first came out with the Nissen, I remember we used to carry 24% persistent dysphagia. We had to knock that all down by making this Nissen shorter and adjust things and so forth. And I think the same thing is true with the LYNX, where it's very hard, but to put something on the esophagus and not have the patient feel it. Now, that being said, the LYNX patients are put on a regular diet, or as more of a solid diet that they can handle. The reason is you want to actuate the beads while it's healing, just like working a tendon repair, so that the beads stay actuated after healing. So that does give a little bit more dysphagia. As you know, in Nissens, most of us put them on a soft diet for a while, or, you know, and so forth, and after a couple of weeks, that goes away. What we're seeing in these patients is that, in the LYNX patients, is that after between about, say, 3, 4 weeks and 6 weeks, they get a dysphagia. I actually think, you know, that's probably still operative edema, and they're having problems with that. Now, you say operative edema that long? Well, all of us have done colostomies, and you know how big those colostomies look, and it takes about 4 to 6 weeks for them to get down to where they're small, and same thing is going on inside here. So it's a temporary thing, and we have to make our patients aware of the fact that that's going to happen. That is the problem. Well, I don't know how to solve that problem, but the idea is not to have persistent dysphagia. And this has been tried to with the LYNX. That's based on how big the device you use. You have to measure for the device. In the Nissen, it was how long and how tight you did the wrap. I've been an advocate that you always have to do it over a 60 French or something like that. Technical problems for persistent dysphagia. But I think temporary dysphagia is always going to be part of it. Your second question was what again?
How difficult is
Yes.
implant?
That's another great benefit of the LYNX, and I think many of these procedures. I'm not so sure about TIF, but the LYNX I know can be removed. And I've been there and see those removals, and it can be done in relatively easy fashion. I want to caution about saying easy, but I mean, it doesn't maybe 10 minutes or so to remove it. There's no disruption of the air. I think that the same thing that Steve talked about with the Stretta, that when you go back in there at that point, you can do a Nissen and anything else if you have to or want to. And there's been a number of these removed. I think the removal rate on the LYNX is going to be around about 2%, just general. I think that's going to be because it was either too tight or patients are unhappy with it or something. And that can be removed. Some of these have gone on to have a Nissen at the same time. There's over 1,000 of them in now. So we're getting pretty good comfort level with that. And that's a big, big benefit of the procedure. As you know, you get down to the second or third repair of a Nissen, you're moving towards an esophagectomy. And that's horrendous for a benign disease. So that's what I mean. Get away from those things that are doing that. There's a place for a Nissen, but this, I think we can reverse it without having those worries that it's going to get more severe.
Thank you.
Thank you very much.